Hi there. How's everyone doing tonight? My name's Daniel Foss, and tonight my DSM presentation is going to be on mania, bipolar manic depressive disorder. Bipolar manic episode, more descriptive of mania, and then we have bipolar 2, which is a separate case altogether. Bipolar manic depressive disorder is arguably both the youngest in new definition and quite possibly one of the oldest forms of major mental illness. It was in ancient Greco time, Roman writings from physicians and scholars that the concepts of syndromes were designated as mania and melancholia. So we begin there. Uh, so mania was formerly melancholia and mania. It was formerly manic depression. Mania is a euphoric, full of energy, negatively affecting activities of daily life behaviors. Mania is now manic episodes, and that is a diagnostic specifier, signifier for bipolar disorder. Just worked for me following manic depressive disorder and bipolar disorder through history, just with some quotes. Boerhaave was a physicist, philosopher in 1735. If melancholy increases so far that from the great motion of liquid in the brain, the patient be thrown into a wild fury, it is called madness or mania, which differs only in degree from the sorrowful kind of melancholia. It is now its offspring produced from the same causes, different sides of the same coin. And then Carl Abram, noted psychiatrist in 1988, the onset of mania occurs when repression is no longer able to resist the assaults of the repressed instincts. Obviously, a view along the Freudian scope. And then in 2017, Rachel Maddox, a current sufferer of bipolar disorder. One of the manifestations of depression for me is that I lose my will, and I thereby lose my ability to focus. I don't think I'll ever have the day-to-day consistency in my performance like this American life has. If I'm not depressed and I'm on and I can focus and I can think through something hard and without interruption and without existential emptiness, that makes me come from depression. That gives me not mania, but I exult. I exult in being not depressed. This is an interesting way to look at what it feels like for someone. Currently, the DSM-5, Diagnostic Statistic Manual of Mental Disorders, does not list unipolar mania as a specific psychiatric disorder. Instead, it's been integrated into bipolar 1 disorder by coding manic episodes as elements of bipolar 1. The future ICD-11 is expected to follow suit with mental in the future. Current stats, prevalence of bipolar disorder among adults, 2.9% and 2.8% of females. Pretty right across the board. 4.4% of the U.S. population experience bipolar disorder at some time in their lives. Whether it be manic or depressive, it has to be both together to reach bipolar diagnosis. Prevalence of bipolar disorder in adolescence. It's a little bit higher in females, being 3.3% and 2.6% for males. An interesting statistical part of this is that 2.9% of adolescents experience bipolar disorder, and 2.6% have severe impairment from that disorder. So here's how it looks. You have the manic side, and you have the depressive side. Together, you end up with bipolar disorder. And bipolar illness is a treatable illness. It's marked by extreme changes in mood, thoughts, energy level, and behaviors. Your mood alternates between the poles, the mania highs and depressive lows. Mood changes can last from hours to months. Hypomanic episodes are slightly different. They're episodes which are persistently elevated, expansive, or irritable mood, and abnormally increased in persistent levels of energy. When you look at the picture up here, you can see that manic episodes generally have an onset between 18 and 30 years of age. Yeah, you have elevated mood, speech is loud, rapid, vulgar, questionable weight loss, grandiose delusions. You look here over here on the depressive side, previous manic episodes. That's what ties it together. 1 + 1 does equal 2. Um, Increased anger and irritability, and you continue with the depressive symptoms. May have agitated or movement retardation, even the depressive one. So you get really, this is an impairing mood disorder. This statistic shows 82.9% of people with bipolar disorder have serious impairment. That means it affects their activities of daily living. Highest percent of serious impairment among all mood disorders. And just some associated terminology. There was bipolar 1, bipolar 2, and then the specifiers for type of bipolar 1. You get anxious distress, mixed features, rapid cycling, which happens more commonly in the females. There's melancholic features, atypical, mood congruent, mood incongruent, psychotic features. There can be catatonia, postpartum onset, seasonal pattern. Numerous ways that bipolar presents with the additional specifiers. 83% have serious impairment. Typical symptoms of mania be increased physical inactivity, heightened mood, excessive irritability, decreased need for sleep without racing thoughts, increased sexual drive, reckless behavior. Clearly, risk and prognostic factors. Environmentally, bipolar is more common in high than in low-income countries. Separated, divorced, widowed individuals higher rates of bipolar 1 than individuals married who have never been married, but the direction of the association is unclear as to whether married has anything to do with it. Genetically and physiologically, if a family history is, there's an average of 10-fold increased risk among adult relatives of individuals with bipolar 1 and bipolar 2. And the magnitude of risk increases with degree of kinship. Schizophrenia and bipolar likely share a genetic origin reflected in familial aggregation of a schizophrenia and bipolar. And certain course modifiers after an individual is manic episode with psychotic features. Subsequent manic episodes are more likely to include psychotic features. Interesting study I ran into by the Heinz C. Richter Bipolar Research Fund in cooperation with the University of Michigan. This was a 10-plus year study, 1,100 bipolar clients. The results, indicators for bipolar disorder, mania, depressive disorder, migraine headaches are increased, childhood trauma, high levels of sedentary fats, decrease in gut bacteria, neurotic tendencies for men are an indicator, a range of cognitive abilities with newer drugs. Interestingly enough, stem cells were taken from controls and from the bipolar population, and when the stem cells were prompted for growth into nerve cells, after growth, those nerve cells were 2 to 3 times more likely to be excited. And when they excited, and the excitation waned at a much slower rate, but then it shut off, basically. An interesting, strange thing. Just some new things going on, the 2 genes. The ANK3 was most interesting because there's been several studies on this gene. It's a repeat containing protein, so it reprocesses proteins back into the body, basically. And so thereby it encodes as uncharacterized ANKin, because this ANK3 is binded with the calcium 2. And upon that, it's eliminated phospholipids from its construction. And because of that, those it receives 2 independent signals at the same time. whereas there should only be one existing as for its measure of protein synthesis. It's just interesting to me what we're finding out from the brain, and the research that's currently going on. So let's look at the DSM. The DSM explains a manic episode as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased energy or activity, lasting at least 1 week and present most of the day, nearly every day, or any duration. If a hospitalization is necessary, B, during the period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, 4 if the mood is only irritable, hypomanic, are present to a significant degree and represent a noticeable change from the usual behavior. 1, inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual, or pressure to keep talking, flight of ideas or subjective experience are that thoughts are racing, distractibility, increase in goal-directed activity, excessive involvement in activities that have a high potential for painful consequences. C, the mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features present. The episode is not attributable to the physiological effects of a substance, drug, medication, or other treatment, or another medical condition. One note, full manic episode that emerges during antidepressant treatment but persists at a fully syndromal level beyond the physiological effect of the treatment is sufficient evidence for a manic episode, and therefore a bipolar 1 diagnosis. Note 2. Criteria A through D constitute a manic episode. At least 1 lifetime manic episode is required for the diagnosis of bipolar 1 disorder. That's where the DSM stands on that. Something that I find quite shocking is that suicide risk is 15 times more likely than in the general population. In fact, it's estimated that up to a full 25% of people who attempt and complete suicide are bipolar. According to the DSM, there's culture-related diagnostic issues. Little information exists on specific cultural differences in the expression of bipolar 1 disorder. Difficulty in this is there's no transcultural validation between our testing and the other nation's testings. Even it's pointed out in one U.S. study, 12-month prevalence of bipolar 1 was lower for Afro-Caribbeans than for African Americans or white. There's just these kind of discrepancies continually question if there is, and what are the culturally related diagnostic issues. Gender-related diagnostic issues. Females are more likely to experience rapid cycling, as was stated earlier, and mixed states, and to a pattern of comorbidity that differ from those of males, including higher rates of lifetime eating disorders. Females with bipolar 1 or 2 disorder are more likely to experience depressive symptoms than males. They also have a higher lifetime risk of alcohol use disorder than do males, and a much greater likelihood of alcohol use disorder than do females in the general population. Making the diagnosis, DSM-5 criteria. We went over them. Complete understanding of the biological, psychological, and sociocultural perspectives is required in the assessment. Doing a clinical assessment, a dimensional assessment in office with the person or in the hospital, as a structured interview can be done, and that can be helpful. Psychological testing, self-assessments, review of their medical history, gaining that comprehensive picture of not just what they present as now, but what they present as prior. Self-report of symptoms is oftentimes beneficial in diagnosing a person, wherein you can, if you can follow them over time, you can get from the neural self reports the swings of the moods. Having them client do mood charting, so they follow themselves daily and chart on how their mood is doing. Definitely when assessing someone who maybe is questioned to be bipolar, doing suicide rating assessments to gain information as to their state of mind on that. Review of family history if the family has any bipolar disease or schizophrenia, any history with their parents or further relatives. And definitely any interactions that someone's had with the legal system. Oftentimes there is, with severe impairment, there is interaction with the legal system, and unusual systems are, unusual events are presented. Treatment. As with any treatment, but especially with mania and bipolar disease, we must understand that this disorder can progressively worsen over time. And any treatment modalities need to be flexible in order to address the vast array of psychosocial domains and the problems that can occur with fluctuating moods and vacillating energy levels. And a person, it becomes difficult. Current treatments: antipsychotics, neuroleptics. First generation typical will be lithium. Second generation atypical will be all olanzapine, quetiapine, and lorazepam. Cognitive therapy is definitely my choice in this. I think we've reached a point where cognitive therapy, especially mindful-based cognitive therapy, is getting there. The cognitive therapy through identification of their patient's cognitive distortions, identification of dysfunctional patterns of thought in the client, and examine mania and depression related behaviors in the client. Help the client become aware of triggers. Integrated behavioral therapy has been effective. Peer support group therapy, family therapy, and combination therapy of all. It needs to be a complete and comprehensive treatment plan with goals, objectives, and strategies. A flexible continuum of care that allows flexible application of modalities based on the treatment plan. And a care model supporting treatment of patients within the community and in the primary care setting also. And then we have some references that I did. And I thought I needed to do an annotated bibliography, so we have one of those. That's about it. Thank you. Everyone have a great day.